Well, as Mark said, it's really fun to be back in this room. I had Saturday mornings when I first joined the faculty, we had a student lecture series in this room. And in those days, students at the university went to school 6 days a week, including Saturdays. And so I was in charge to get the students here, and then the faculty would come. And the thing that always irked me was that the students would be here ready to learn, listen to a lecture, and the faculty person would show up and say, "Oh, I hate to get up on Saturday morning." But that was the way it was. And then we had our own in-house student examination at the end of the third year, which was a big entry event for students into the fourth year and on with medical school. Well, I'm going to talk about neutrophils for the next little bit. Not everything there is to know about them, but a bit. And the first slide is just about the conference and how to connect. And then my title is Neutropenia Bench to Bedside, but more importantly, I'd like to say nurturing your curiosity, because I have done research for a long time, and in the audience is Vaughan McCarran, who's my chief laboratory colleague now, and he and I were talking about a R01 this morning, and we're still very much engaged in research. I have a few disclosures, but not much. I've worked with a number of companies over my time. You know, if you're trying to translate from basic research to clinical medicine, you're nearly always dealing with some commercial entity. And the two that I'll mention here are three, are the company Amgen that I worked with for a long time, Anormed, and then X4 Pharma, a Boston company I've worked with most recently, but I have no financial relationships with any of these companies now. I think that one of the things I wanted to impress upon you is thinking about how you got to where you are, as you also might be thinking about where you might be headed. But my boyhood was in Tennessee. I grew up with cows and chickens and dogs, and raising a big garden to feed our family, because I can remember World War II and the hardships that we faced with rationing and so on. So we were basically self-sufficient, and I liked it. I liked the physical activity, but also actually watching things grow, and the biology you could see in the garden or with raising chickens and animals. And I saved all my money, and I bought a cow when I was about 13. And my cow was in the pasture in Tennessee, and at that time the disease brucellosis was endemic. And my cow got brucellosis, and on a Sunday evening I came home to my cow having had the calf, and it was dead in the pasture, which was the signal that the cow was very ill and had to be put to death. Anyway, it was a very telling experience in my life, because had it not happened, I might have been a Tennessee farmer. But I didn't do that. I went to college, and then, as Mark mentioned, to medical school, and then interned in internal medicine. And as I look back on that part of my career, I think that the theme is it's in life more fun to say yes than to say no. You know, opportunities come when you say yes, and often when you don't know exactly what's around the corner. I went to the NIH during the Vietnam War, a very tense time in America, but I was lucky. I got a job in what was called the LCI, or the Laboratory for Clinical Investigation, with 5 other young doctors, and we bonded very closely. I mean, we had a great boss who really expressed his interest in us as people, as well as in the substance of the research or whatever work we were doing. And we were on the 12th floor of the clinical center at the NIH. If you've been there, big brick building. Our Senator Warren Magnuson was instrumental in the building of that building as in the building of this building. Anyway, our laboratory was focused on host defense mechanisms, or why people are susceptible to infection or how we defend ourselves from infection, and also on the tough infections with fungi and viruses. As I think about that part of my career, and you might think about where you are in your career, one of the early steps was that Tony Fauci and I sat side by side, little tiny cubicles, less than 3 feet space we had. But anyway, we didn't either of us know exactly what we wanted to do, but we knew the area we were in, and we flipped a coin. And he got lymphocytes to study, and I got neutrophils. So that's how I got to this area of research. But it was good, and Shelley was a good boss. And he assigned me a patient with periodic fever because his primary interest was in the mechanisms for fever. And that was before we had IL-1 or many of the other pyrogens identified. We had what was called endogenous pyrogen, which you may know was discovered to be a product of white blood cells by a man named Paul Beeson, who late in his life, he was a University of Washington graduate, but late in his life, or actually the same year that I joined the faculty, he joined the faculty. He came as a professor, the head of the department at Oxford, and I came from the NIH. But we had a good friendship, but he had been the man to name what we called then endogenous pyrogen. So in the laboratory focus on fever, there was a lot of interest in neutrophils and leukocytes because they were potentially the cells that produced the leukocyte pyrogen. And then we were interested in periodic fever as to why people got fever. And he assigned me a patient with the disease cyclic neutropenia, about which at that time I knew nothing. I had never heard of it, but I said, you know, like a good student, or certainly a Southern boy, I said, yes, sir, and did. And it was really a blessing for me to accept that responsibility. The other real blessing was at the same time at Washington State University, at the veterinary school, they had discovered that there were gray collie dogs, dogs which had pigmentary dilution, which had also a similar disease of cyclic neutropenia. And as I've already told you, I liked animals, and so the dogs were a real challenge for me because they were sick and died at a very young age, and so I took them on as patients. And in fact, my children and many of my neighbors thought I was a dog doctor because of my devotion to these dogs. Anyway, neutropenia in that era, mid-60s, now that's a while back, but was pretty sketchily known. The main paper in that era was a paper by Gerald Bodie, published in 1966, from studies at the NIH, which showed in patients with cancer, and particularly patients getting early stage chemotherapy, that as their counts dropped, there was a level at which they were very susceptible to infection. And that study in '66 still defines the threshold for what you do in lab medicine in terms of calling that there's a patient who has a very seriously low blood count and you better do something about it. And it's been a very useful study, although we know now a great deal more about the many causes for neutropenia and the varying susceptibility to infection. Just as a reminder of this era of medical progress, you probably recall that it was in the 1870s that Paul Ehrlich identified the stains for blood cells. And actually, that time, which is now 150 years ago, was when you could identify neutrophils as a separate cells from other cells, monocytes and lymphocytes. The disease cyclic neutropenia that I'll talk about a little bit more was first described in 1910. Somebody whose blood counts went down and gone up. And interesting, that same patient was reported in 1933 from the Johns Hopkins Bulletin, still going up and down in the very same pattern. The disease we call agranulocytosis was a name from the 1920s, after a variety of drugs were discovered that caused neutropenia. Aminopyrine was the original drug, but there were many others. People often associate neutropenia with disorders of the spleen. Well, the spleen is a trap for cells that are abnormal, but it probably no such disease as what Doan called primary splenic neutropenia. The condition we call congenital neutropenia really is something we date from the 1950s. There was a description of a hereditary disorder by Herbert Ryman in the late 40s, but there was a Dr. Rolf Kossmann, who was a military doctor assigned to the very far north of Sweden, who first clearly defined a disease that was hereditary that caused severe neutropenia. And I've actually been to the home of this patient. Story I'd love to tell you, but it's not enough time. But very far north, lots of snow. Anyway, the family denied for many years that there was consanguinity in the family, but there was. It was later revealed. And that's how this autosomal recessive disease was identified and described. And you'll still hear people use the term Kossmann's disease or Kossmann's neutropenia. The real era for the burgeoning of interest in neutropenia came with the advent of cancer chemotherapy in the early 1960s. You may recall that era or have read about it. I can remember it. I remember my brother's wife had Hodgkin's disease, and she got a series of chemotherapies before it was discovered that multiple drugs given all at once could be curative, and so she wasn't cured. She just lived for 12 years with complication after complication, and that was one of the signal events that made me particularly interested in this condition. Briefly, the complications of neutropenia. My sister-in-law experienced them all: fever, gingivitis, because you remember the neutrophils are constantly exuded into the mouth. And you and I, everybody who has teeth, have neutrophil exuding there yesterday. And if you had a cookie or a cup of coffee, even more right now. Anyway, these are a pattern of infections, and the worst is what I listed last. That is abdominal pain, ulceration of the colon, and sepsis. And in some of these diseases, there's a particular predilection by the organisms to be clostridial organisms. Clostridial organisms tend to be adherent to the bowel wall and to be right at the portal if something happens to allow their entry. So it's a serious condition and lots of reasons for my long-term interest. One of the other things that makes you interested in the disease is the people. And this is a picture of a book. It's the cover of a book of the poet laureate of the Library of Congress. And his son was my first patient with cyclic neutropenia. And he, in this book, wrote poetry about his son and this illness that came and went and came and went and came and went, and how hard it was to live with a child who had this problem. And I faithfully related to this man and his wife and the patient, the boy, for the rest of his life. One of the signal features for neutropenia, of course, is ulceration in the oral cavity. And this is that boy with the ulcer on the tip of his tongue. But ulcerations along the bite line are very severe and quite common, as with the common, what we call aphthostomatitis, but much more severe with bigger ulcers. And we actually, at one point in this boy, exteriorized his colon at the NIH when he had a septic picture, and you could see the formation of ulcers in the colon at the same time he was developing ulcers in the mouth. So you got a visual impression about how it happened that he got Clostridial bacteremia. Now, one of the things we did at the NIH, and I've tried to do here with some greater difficulty, is to do blood counts regularly, every day, at the same time, under the same conditions as well as you can standardize them. And this is a picture of serial blood counts, CBCs, in a patient with cyclic neutropenia. I think it's the same boy whose tongue I showed you a moment ago. Anyway, the black line, is there a pointer? Black line on the top panel is the neutrophil count going up and down, and the disease has a rigid periodicity, 21 days. And after the 21st day, the count bottoms, or you have a nadir, and the counts are often 0 for a few days, and then they will recover. And you can also see that other cells also appear to oscillate, although with not quite the same exquisitely rigorous, consistent pattern. And it is this cyclical nature and the periodicity that is so remarkable. That is, the same patient has the same period length between the periods of neutropenia every day as long as they live. And we've repeated this many times, but it's a remarkable disease because of this regular periodicity. If it's a woman who has menstrual cycles, it's more regular than the menstrual cycle, and the blood cycles march through the periodicity of the menstrual cycle. And I mentioned the dogs. These are the gray collie dogs. That's the one on your left, and this is a normal litter mate on this side. And these dogs were the focus of my study for a long time. And they, nice collies, purebred. The disease emerged in a colony, a breeding colony in Oklahoma. The people there denied it, but we were certain that's what happened. You know how it is in life. Anyway, the keeping these gray collie dogs alive was my charge. The gray color is because of pigmentary dilution. It's the same thing that makes people gray as they get older. Less melanin per melanocyte and less put into the hair through the transmembrane transfer of the melanin granules. And it's an interesting disease. In the dogs, the periodicity is approximately 13 days, whereas in the humans, it's 21 days. And the basis of that is probably differences in the duration of the developmental period, that is the mitotic and post-mitotic period for the neutrophils in the marrow. We know this from radioisotopic studies that we did and some studies that have been done before that. And so it's an interesting part of the phenomena of blood cell formation, and it's certainly very important. The gray collies had gray coat color. They were delayed in their growth. As you saw, the gray puppy was smaller, and they died within a few weeks or months before I began to take them as my patients. And their disease was autosomal recessive. The human disease was autosomal dominant, so we knew they were probably due to a different molecular mechanism. In the 1960s, our research toolbox was pretty small. And you may think about that in what you're doing. What is your potential research toolbox? It's never been so big. There's so many ways to study something or do research now. But I just showed them here the first 3 or 4 things that you're familiar with. A little vignette is the Coulter counter. That was a new device when I started at the NIH, and I read about them and I said we need one, and we bought one. And it was interesting that we had a new device in my lab, and people came to my door, could we use your Coulter counter? And that was before they became popular. And I learned how it worked and how to take it apart and put it back together, and so it was a real friend. And it has been throughout my career. And counting blood cells electronically, of course, created precision in the field we never had before with manual counting. Another interesting feature of studying neutrophil production of that era was what will stimulate counts to come up. And I gave endotoxin to all kinds of animals and people. to see what the response was, and there are differences, disease-related differences. And then we studied a steroid, etiocalanilone, which was thought to be the cause of periodic fever. Turned out to not be true, but etiocalanilone is a very potent pyrogen, and it hurts. And I injected it into a lot of people. It causes local inflammation. It's very painful, but they get a nice white blood cell response. And I even plasmapheresed them and collected the plasma and saw what happened when you give it to them, back to them and so on. And then corticosteroids, which have been, with us also since the 50s and cause lymphocytopenia and neutrophilia. One of the important parts of my early career, though, and I just mentioned this because of the way things have progressed, were the use of radioisotopes to label cells. And tridethymidine was a 1950s introduction, and you can give tridethymidine and you can label a population of early progenitor cells, and you can follow them in their progression through the bone marrow. And that's how we know how long it takes to make a neutrophil, or most other blood cells, or most other cells in the body. And detailed studies have been conducted. Many of the best studies ever were conducted here in the laboratory of Dr. Finch to look at the kinetics of neutrophil production as well as red blood cell production and so on. An isotope that we used then, we'd never use now, was P32 labeled diisopropyl fluorophosphate. Diisopropyl fluorophosphate is a nerve poison, and P32 is a leukemia-inducing agent. But in the early days of my career, we injected lots of people with these two agents to study the kinetics of neutrophils, because the DFP selectively labeled neutrophils. And that was because of the esterases contained in the granules. So you could follow neutrophils in contrast to lymphocytes or monocytes using that particular isotope, which was developed at University of Utah. What was really the most important, probably, development of that era, and links to later in my career, was developing a way to grow blood cells in an agar petri dish. It was revolutionary, and it led to the definition of what we call colony stimulating factors, or the particular cytokines that stimulate blood cell formation. And then it was the era also of preclinical studies in dogs. Dr. Don Thomas, the Nobel laureate here from the Hutchinson Center, did his studies in dogs at the Imogene Bassett Hospital in northern New York. When in this same era, and with my colleagues at the NIH, I did transplant studies in dogs too. It was one of the ways you could learn. The kinetic story I briefly mentioned, and I won't dwell upon it, but the concept of a delay from the stimulation of formation of cells to the response, that is an increase in the blood counts, is a very important part of hematology that's often missed when you try to think about why is someone neutropenic, or will their counts come up? If I do something now, how long do I have to wait to see something happen? And so knowing about the kinetics for cell production is important. The other part that's important is shown here briefly, and that is that neutrophils migrate through little fenestrae in the bone marrow into the blood, and then in the blood they migrate between a circulating and what's called marginal pool. So when we do a count, we're measuring half of the cells, the other half are marginated somewhere, usually stuck in the lungs. We know that from more recent studies, but at the time we just talked about the marginal pool. And for the most part, these two are in equilibrium. And there are very few conditions which actually lead to an increased proportion of marginated cells. I mentioned the colony assay. This was probably my most important work during my NIH years. In a way, it was work that was started really in two places, in Israel and in Australia, about the same time in the mid-60s when I was beginning my research career. And the original idea was trying to figure out how to stimulate leukemic cells to mature to normal neutrophils. But what was found in the agar system was that the leukemic cells stimulated the normal bone marrow cells to grow and form colonies. And from that came the idea, well, what is it that they're stimulating? What are they making? And that began to unfold as a story around 1970. And the paper that I wrote that was published in Science in 1971, you remember 71? Was this is my hand-drawn diagram, which showed that as the neutrophil counts came up, there was always, and there was more data than this is shown on this panel, there was always a rise in what we saw to be a colony stimulating factor, that is a protein substance we could isolate from the urine that would stimulate cells to grow in the agar method. Okay, so when you were neutropenic, you were beginning to make this substance in abundance, which you leaked out in the urine. And we said in this paper, maybe somewhat arrogantly, I don't know, but we said it was possibly the regulator of neutrophil production. But turned out to be that was what happened. So what happened in my own career was that I came here, we purified this substance to a degree, but I decided to come here for mostly family reasons. And we came here and I joined the faculty in 1974, and I brought the dogs with me. I worked with Tom Price and John Adamson and Clem Finch in hematology, and it was a wonderful period of research. What happened was that a very fine young physician from Germany working at the Sloan Kettering in New York became interested with some researchers there in trying to identify the hormones that regulated blood cell production. And they identified several substances they thought were the regulator, and you may know there's a substance called GM-CSF. Most of us in that era thought this was going to be the key substance for regulating blood cell production. But it turned out that wasn't true. It turned out that this molecule I've shown here, just in terms of its helical structure that gives it its three-dimensional shape, was the key regulator of neutrophil production. And the substance was purified actually the protein was purified at the Sloan Kettering. And then in this era, early 80s, no one there had the skill to identify the DNA sequence that went with the protein. But a young PhD from UCLA was recruited, and at the company, the little tiny company Amgen then, began the process of identifying enough of the genetic material to be able to in vitro produce G-CSF in E. coli. And it was a monumental event. That person's name is Larry Souza. And what happened then is, in this interval between when I came here and the mid-80s, was the cloning of the gene, the beginning of the production of this cytokine, the second product of Amgen after erythropoietin. And I went to Amgen to say, could we have a little to see if it might be something that would alter the cycle in a patient with cyclic neutropenia. Because I thought that if it was the response when the counts were low, that if you gave it earlier, then you might not have such a dip. And I went with an earnest belief that this was going to be true. I think probably disproportionate to what I knew, but I knew if I didn't be somewhat of a salesman, I wouldn't get my story across. So I did. And this is what happened. The original patient, his initials are shown here, but you don't know who he is, I guess. But anyway, he was a boy who lived here in Seattle, and we knew the family because his father was a school teacher where my wife was the PTA principal, or PTA president. And so we knew the family because he also went to the same pediatrician as my kids. And we knew him because the family had seen that I knew something about this disease and was interested. Anyway, this was the first patient. We treat him here on the Clinical Research Center, or now it's called the TRU. And you can see his counts on the far side of the panel were always very low, but he had these protracted periods of neutropenia. And then when we began him on intravenous G-CSF, you can see that the peaks were higher, and at a higher dose they were even higher, and then at an intermediate dose they were lower. The really significant part of the slide is the first two dosing were intravenously, and then we gave this agent subcutaneously, and that worked too. And we didn't expect that at first, but what an advance to be able to simplify administration, and resulting in that this, what was then young man, is now much older. That was more than 30 years ago. And he's been taking G-CSF self-injected every day for more than 30 years. And I just recall saying to him, I think we'll know in a couple of 3 weeks whether this works. I had no idea that it would last so long, because in a sense he's the person out there at the front of the line having the most experience and giving us the most information about efficacy and safety. And there's no loss of effectiveness as with this agent, because it's a natural hormone, which is really very important. Here he is with Donald Metcalf, the man who originally coined the term colony stimulating factor. Dr. Metcalf is no longer with us, but he was a professor and director at the Walter and Eliza Hall Institute in Melbourne, Australia. What we did, like in many research projects, we went from a phase 2 study to a phase 3 study, and not to dwell upon this, but we showed that other people responded in the same way, and it wasn't exclusively an effect with the disease cyclic neutropenia, but almost all the types of neutropenia that we could round up would respond. And they would respond by having fewer infections and less antibiotics, and overall a better life. And I think the thing that has been satisfying to me over all these years is the better life. That is, going to school, having kids, having a family, getting a job, and so on. And now, in talking about neutropenia, I focused just on one little niche to begin with, because that's how I, in a way, got into this in my career. And in your career, there's probably something either happened or in progress that will define what you do and focus on. But in terms of causes of neutropenia, there are many causes, and there's a story that goes with each of them. And the area where Vaughan and I particularly focused is on this severe chronic neutropenia, which is due to congenital or genetic causes. And one of the ways we did this was family studies. You have a patient, you learn more by talking to them, and anybody else with this in your family, and sometimes they'll say no, and the answer is really yes. And then you have to say, really, you know, and go deeper. And you learn that most families have somebody who's the historian, and there's a lot of other people who don't know very much about the family history. But we, based on what I knew from the 1940s, I said there must be a genetic cause, and we should try to find it. And so I searched with lots of families and found some. These are US families, which were in our original set of families for identifying the gene. This is an Australian family, which was even much more informative. And if you go into this area, you'll find that if you can find some avenue to identify a pattern, then you can begin the search for the genetic cause for diseases like this. Well, we spent about 10 years before we had any pay dirt. The problem was we began in 1989 before automated sequencing before the whole human chromosome had been mapped. And we had a lot of poor progress, slow progress, and interruption in funding a little bit, but we persisted. And I think our persistence probably helped us with funding, even when we didn't have much to say. But eventually we found that the locus was at the tip of chromosome 19. This is work done here with Dr. Marshall Horwitz, and then in the Department of Medicine and now in pathology. And we mapped to this locus based on this set of families I just showed you. And we found that the locus was on chromosome 19, right at the tip of the chromosome, where there were not markers earlier in that period of research. Neutrophil elastase is a very abundant protein in neutrophils. It's a protease that I usually say can digest almost anything. It's like meat tenderizer in a way. And so it has great non-specificity, and we don't actually know how essential it is in the body because of the redundancy in the proteases in neutrophils. But anyway, mutations in this protease lead to its failure to traffic normally, and to the abnormality that's so obvious if you look at bone marrow. That is, if this is the normal pathway shown on the top, on the bottom is the aberrant development, where you have cells that are promyelocytes and myelocytes, but not much beyond in the maturation pathway. In the old literature, it's called maturation arrest, but I've always said that was a very lousy term, because it isn't that something is arrested, it's that the cells that are being made are dying when they reach to a certain stage in development. And what's happened over the years since we discovered that neutrophil elastase was the cause for cyclic and also for congenital neutropenia, in most cases, there's been a lot of studies we've done and others have done about mechanisms. And the mutated protease is, in most cases we know, probably misfolded, and it leads to activation of the process of apoptosis, or cell death from within. So the rest of the marrow cells look okay, but the neutrophils are selectively lost. And it's this description that led to work we did long ago that we said it's ineffective hematopoiesis. You've got lots of churning of the developing cells, or the myeloproliferative compartment, but no product. So it's ineffective granulopoiesis. Now, Vaughan and I and a number of people have been involved in looking at the mutations in this gene that might be associated with the disease. And this is probably not a quite up-to-date list, but there are more than 200 mutations have been identified all over the world, consistent with our original work, but actually with varying severity. And there are mutations associated with leukemic transformation, and there are other mutations that are associated with an easy response to G-CSF, and then others which don't respond at all. And part of our interest these days is trying to understand that. And then there are other options of treatment other than the G-CSF molecule. And the work that we did, which was, I think, the original work to define the genetic and molecular mechanisms for elastase-associated neutropenia, led to a great interest in finding other genetic causes for neutropenia. And this is just a partial list, and it's growing. And it's been satisfying to us to have been part of the beginning. It's also hard to keep up, because of the rate of discovery. You can map these mutations to parts of the cell, though, and you can see what a precious and fragile something a neutrophil is. because of the many ways that the process can go awry before you get a normal cell. And it's almost amazing that we get normal cells, but we do. And this is just a schematic to show the sites within the cell where you could have a mutant protein that leads to some abnormality, but usually neutropenia. Now here's the heart of my talk. So Mark asked me if I would talk, and I said sure. And the key conversation was he told me he had seen a blood smear, and he thought he knew the diagnosis. And he was right. So I want to applaud Mark for doing that. And I want to encourage you in your laboratory work, wherever it is, to look carefully at what you see and recognize what you don't understand. You know, because there's a world of discovery out there just being a good observer. Anyway, Mark saw a blood smear that looked like this. Where are the other white cells? You know, and the whole smear looked like this. And then the neutrophil has this long kind of a string between the two lobes of the neutrophil. It looks like the bilobed cell, but if you look at more cells, you can find they're all kind of got this string. And I usually tell people it looks like if you take a tube of blood and put it in your pocket, which you shouldn't do, purple tube, and forget it, and then you look at it the next day, the cells have aged, and they look like this. And it's a feature of cells that have a marrow dwell time that's too long, and then have eventually, for some reason, escaped the marrow into the blood. Now, this condition was called for a long time myelocathexis. And I showed here the two guys who I identify as discovering this. One on the left is Dr. Zulzer, who I knew at the NIH. And he was a very careful pathologist. Wolf was his first name, Wolf Zulzer. Anyway, the remarkable part is that another doctor, Dr. Krill, identified the same abnormality in the same patient, and they both published the same story in the New England Journal of Medicine, the same date with a different name, and nobody knew it. You can say that would never happen now, but it happened. And I was on a bus one time with Dr. Krill, and I said, "How did that happen?" He said, "I don't know. I guess it was the editor's fault." Anyway, it's an interesting condition. The feature of that is a flashpoint is the feature of warts, and that's how the name was changed from myelocathexis to WHIM syndrome, because of the common warts. But not everybody has warts. It's about 60% or so. And the patients have hypogammaglobulinemia. But it's not severe. It's not like the agamaglobulinemia and the other diseases we relate primarily to the production of gamma globulin. But it is an immunodeficiency syndrome, and it is associated with severe lymphocytopenia as well as neutropenia. The neutropenia is the part that's best studied, and it's caused by mutations in the CXCR4 gene. I don't know if you know these chemokine receptor genes. It's a really interesting area of biology. There are a whole bunch of them. I was at a meeting last week and talked to somebody about CXCR3, and I have a paper review today about CXCR2. CXCR2 is the receptor for IL-8. IL-8 is a primary stimulus for attracting neutrophils from the bone marrow. And the people with CXCR2 mutations have neutropenia also. But where we focus our research is on this more classic WHIM syndrome due to CXCR4 mutations. And the features are the patients have neutropenia and recurrent cellulitis, usually not bacteremia. They're disabled by other things, the warts on their feet, and hearing loss, so they go deaf. And then the women get an abnormal pap smear because of papillomavirus infection, and they get cervical cancer. And it's a high rate. French studies say probably 30% have, but it may be higher than that if you have longitudinal studies. And then they're also susceptible to other malignancies, including leukemia and lymphoma. But the vaginal cancer part is the thing that's so dramatic. And I know a nice lady with this disease from Spokane who had her uterus just whittled on trying to get at the tumor, but unsuccessful, and she eventually died. Anyway, the marrow in these people is interesting, and it's not hard to diagnose if you know what Mark knew when he saw this patient. You can see here even more vividly neutrophils like one there, quarter of the center, which has this stringy shape to the connection of the lobes of the neutrophils. And we did studies in the late 90s of the mechanism and showed that we could see phagocytomes in the marrow where the macrophages had actually ingested the effete neutrophils, which didn't leave the marrow but died there. And this is an early stage neutrophil which has features of apoptosis, and another in the late stages of apoptosis. And then the normal promyelocyte with an apoptotic neutrophil where the neutrophil chromatin is very condensed. The feature that I mentioned was trouble walking. This is the banker lady from Spokane's feet. So she had shoes that should have been size 7 but were size 12 in order to walk. And you'll never see this anywhere else other than in this syndrome, WHIM syndrome. It's an autosomal dominant disease like most of the things we've identified in the U.S. that cause neutropenia on a congenital basis. Why is that? Because America is an outbred society. So there was an age when some recessive diseases were found in clusters of people who intermarried, but there's uncommon in America now. So the recessive diseases are usually found in other populations. This is a dominant disease, WHIM syndrome, and this is the largest series that anyone has ever created of the patterns of inheritance in a paper we published a couple of years ago. One of the interesting parts of this story that merged in my career was I was asked one time by some researchers who were creating a company in, just outside of Vancouver, BC, about a drug that had been tried in people with HIV infection that they thought might be a drug that would be in some way amplify the effects of the then antiviral therapies because it blocked or seemed to block CXCR4. And when they gave this drug to some young men at Johns Hopkins with HIV, they found that in fact it raised their white blood cell counts. So they came to me and said, do you think this might be a substitute for G-CSF? And I said, no, the response is too puny, too small. But what happened is I said, let me see the blood count information you had. It was very meager. I was surprised. But I said it might be important what else went up. And that led to our discovery that the parent of the drug we studied in this clinical trial in WHIM syndrome was the drug pyrexafor. I don't know if you heard of it, but it's the most potent stimulus for the release of hematopoietic stem cells from the marrow to the blood. And it's a very important drug right now. If you read about stem cell therapy or gene therapy for sickle cell anemia, that trial is only possible because of the discovery of pyrexafor, because there was no other way to mobilize the cells in sickle cell patients. Anyway, there on the shelf when we were developing it was a orally absorbed form of the drug, which got the name mavorixafor. I don't know why, but anyway, it did. And we conducted first a preliminary trial of giving the drug pyrexafor to patients with WHIM syndrome to see if it would mobilize the cells from these patients with mutations in CXCR4, a drug that seemed to target that specific receptor. And we know more now than we did then, But the problem with the receptor is it binds but does not release cells from the marrow. So they're stuck there. And we thought if we might unstick them, if you will, or cause them to be released by blocking this receptor, that they might float into the blood and the counts would come up. And we did a trial now 10 years ago with Pyrexafor, and it worked. And so when the drug Mavorixafor came along, we said we'd do a clinical trial because it was an oral drug, which would be much better therapeutically. And we did a trial, and one of the patients in this trial was particularly noteworthy. On what you see is the right panel are her, I guess on the left, on that panel is her hands and the warts on her hands before we gave her this drug, and then her hands after she had been on this drug, I think for, looks like about a year. Gradual resolution of the warts. Nothing else had ever worked. And young woman, very happy, will have that improvement. And so based on that trial, which also suggested reduced bacterial infections, we participated in a phase 3 study. It was a 52-week study with 35 patients, some relatively young. You can see their counts. And I just point this out. If you were Mark in the laboratory and you saw a patient with a total white blood cell count of 1,000 or so, and they looked, or you were told they were relatively well, there's a good chance they have WHIM syndrome or one of the diseases in this family. There's just nothing else that quite does this. And you can see how low the average or the median lymphocyte and neutrophil counts were. And then the study is about to be published in the journal Blood. It's been accepted for publication. What it shows is if you just look at the peaks of their counts, these are the 4 hours after the drug, and you follow across, you can see that the drug is effective to raise both lymphocyte and neutrophil counts. And that response is more or less the same over a period of time. And then if you look at the response in terms of febrile illnesses, if the blue bars are the Mavorixafor and the red bars are the placebo, you can see there are more or longer red bars than blue bars, or that there's an effect to diminish febrile illness. Now what the trial didn't tell us is, do you improve immunity or the response to the virus infection, the papillomavirus infection, or can you prevent cervical cancer? But that's going to take a much longer study. But the hope is it might be a therapy which would be a orally absorbed immunotherapy for people with this kind of immunodeficiency disease. Now, and I think that the information is at the FDA right now, and it'll probably be approved. In terms of where we go from here, because of the pharmacology of the drug, that is orally absorbed drug that promotes cell release, I've thought it may have a place as an immunostimulant in other situations. I told the company one time, I don't know whether they believe me or not, I said, how about old people, where you have, the senescence of the immune system, where we give bigger doses of influenza vaccine, right, to older people. And there's also other conditions where there may be an immunostimulant effect, because the immune response depends not only upon blood counts, but also this great reservoir of lymphocytes and monocytes in tissues, that is in the spleen and other tissues in the body. I mean, we just see a tiny little peak when we do a blood count. So the hope is that it might have some broader possibilities, and I think it likely will. So my conclusions are, or if you will, the take-home message is that we've come a long way in understanding neutropenia, particularly as caused by genetic causes. We still have a lot of conditions where we don't really understand the mechanism. We know, of course, with chemotherapy what happens, but a lot of things we don't know. But to be effective in this field, you need to have good diagnostic techniques, and two of the cornerstones are accurate blood cell counting. That takes me back to the Coulter counter, or we're working now on a home device for monitoring blood counts, and also genetic testing. And then in terms of treatment, G-CSF has proven to be a very effective therapy. We've written about this because we've conducted a registry of people for 30 years, so we know a good bit about what happens when you give the drug. And we know that the disease I focused on at first, cyclic neutropenia, has a precise genetic cause. We know a good bit about the mechanism, and we're working on other ways to try to approach them therapeutically. And we have this disease that Mark diagnosed, WHIM syndrome, which has a specific cause, and we think we may have a therapy that will be approved this spring by the FDA. But I'm quick to say there's a lot still to learn. In terms of your career, and we're all somewhere in our career, I think there's great value in nurturing your curiosity. Be curious today about something. And in terms of my experience, finding a good mentor is critical. And then to learn about whatever it is you're interested in to the depths you can. And don't give up. And you can test your ideas. Some are good and some are not, and you can get useful criticism. And then I've encouraged lots of people in terms of writing. I say start, write something down and show it to me. Don't be afraid to. And then you can eventually often create something that's useful to other people or will be published. And then finally, I'd say, at least I've enjoyed my career, and I hope you will too. Thank you very much. I've probably talked a bit long, I apologize, but I'm happy to answer questions. Yes?
That was fun, thank you. Why is it cyclic? And why didn't G-CSF fix the absolute nadir of zero?
Well, the cycle is because we believe that the cells are being made, but as soon as they're made, they produce their own poison. So you have a proliferative marrow that fails, but doesn't fail completely. So in the body, as I showed in a picture, we believe that the G-CSF level rises sufficiently to be an anti-apoptotic factor and a stimulus to production, so the counts will rise, but not to maintain a normal level, but to fall again because of the effects of the mutant elastase that's produced within the cells.
And we don't know what that poison is.
Well, the poison, we believe, is the mutant neutrophil elastase protease that's in the cytoplasm that we don't know exactly what are the critical targets for that protease, but it's not normally packaged into the granule of the neutrophil. It sits in the cytoplasm as probably an active enzyme.
But why wouldn't new neutrophils stimulated by your drug fill in that nadir?
Well, it does to a little degree, and the clinical benefit is it shortens the nadir because the G-CSF also has an effect to accelerate production. We studied this at one time by giving treated thymidine to people, normal volunteers, on the CRC here. And you can show that if you give them G-CSF, you roughly diminish the dwell time, or the time to produce a neutrophil, by 50%. So you accelerate production and you get a little dip, but it's not very long, and the body tolerates that much better. But there's a part of my explanation which I'm not satisfied with, because there are holes where we really don't know. And there was a time when people thought that everyone had cyclical blood cell production. You just couldn't see it. But we did studies at the NIH in normal volunteers to say that's probably not the case. The best work in this area, I think, was by a mathematician who actually got his PhD in physiology here, a man named Mike Mackey, who created models where the key feature is the time delay between the stimulus and the response. So the time delay in any system tends to make it oscillate. And then in his model, the worse the effect to suppress cell production, the greater the likelihood that the system will oscillate until you get to the point where there's no production at all. I could readily show you his work. Any other questions from the room? Yes. Mark.
Well, first of all, thank you so much for a great talk. I loved everything about it except that picture you showed. I don't know. So
It's from the internet, you know.
yeah, the internet. My question about mavorixafor, do you think it's got some potential in other conditions with low-grade neutropenia where we don't have great interventions? I'm thinking about lupus, for example, and some patients with autoimmune neutropenia that don't have severe neutropenia.
I'd say yes. We've actually had an abstract published that shows that it is effective in that category of people. Sometimes we call it idiopathic neutropenia, but it would be the same picture you'd see in a patient with lupus. And the reason it would work is they have neutrophils usually in the marrow, but low counts in the blood. And the ones in the blood are the cells that are in surveillance mode. The ones in the marrow are in the reserve or called forth. And so lupus patients and many other of the autoimmune category get a delayed response. So they're often getting sick, but they don't get real sick. And there's a clinical trial now started in that category of patients. Yes?
We have, just to let you know, there's about 50 online attendees, and we have a question. Can you comment on why neutrophils like to be in the lung?
Well, part of the circulation, of course, is you got to go through the lungs, right? But the other part is that the capillaries of the lung are small, and they have to go through tiny spaces, and they get stuck there. Another reason is the lung is a kind of a dirty place with lots of stimuli there for the release of cytokines that tend to immobilize neutrophils. And so they're there if you get a respiratory infection, because that's a good place for them to be, I guess. But the lungs are a rich source, and studies have been done principally at UBC to show that the lung is the place where most of the so-called margination occurs because of the pattern of the vasculature. And if you give catecholamines, you can flush them out if you want to. Any other questions? Did anybody fall asleep? I don't think so. Well, thank you very much.